Welcome to the Latin America-Africa Joint Webinar, LAT-AF 2.1. For those who are attending for the first time, LAT-AF is a joint effort of doctors from Latin America and from Africa, joined by their passion for the treatment of veins and lymphatics and their passion for education. This time, we are pleased and honored to host a third continent, which is North America, represented by the esteemed Dr. Zoe Doyle, Dr. Pauline Martinbeau of Canada, and Dr. Javier Zeraldi of Mexico. I would like to introduce my colleague and fellow friend, Dr. Oscar Bottini, a very well-known professor of philology of Argentina, whose good vision made this educational event possible. It's my pleasure to introduce our superstars, Dr. Lorena Grillo and Dr. Wasila Taha. Both are continental chairpersons in the American Venous Lymphatic Society, who are also co-chairpersons of this meeting and who will moderate the greater part of the meeting. We are honored today to have the contributions of Dr. Antonius Gasparis, President of the American Venous Forum, and Dr. Kathleen Gibson, member of the board of the American Venous and Lymphatic Association. All the credit should go to Professor Sergio Gerassini. He's the real man behind this event, whose infinite support and strong commitment were key to the success of this event. Finally, we are grateful to Servier for their unconditional support of all our Latin America-Africa joint webinars. Today, it's about lymphatics and lymphedema. We all need to know more about it. In addition, the eminent professor, Dr. Thomas Urbanek, will give us an update about when to use venoactive drugs in the venous and lymphatic diseases. I would like to remind you that we have translation in 3 languages, English, Spanish, and French. Please click on the channel that's suitable for you. And now it's my pleasure to give the word to Professor Bottini, who will welcome our Latin American colleagues. Please, Professor.
Gracias a todos. Estamos una vez más en esta webinars, que es un verdadero puente entre Latinoamérica y África, siempre potenciando la unidad al resto del mundo, en esta oportunidad, como ha mencionado Rayad, a Estados Unidos y el resto de Norteamérica, Canadá y México. Es un placer para mí hablarles en español a todos los colegas de habla hispana. Recuerden que pueden conectarse en el canal en español y pueden desde allí hacer sus preguntas. Estaremos atentos para poderle evacuar todas las dudas. Gracias.
Professor Lorena Grillo, could you please moderate the next part of this session? Thank you. We can't hear you. Unmute.
Iniciar con la presentación de la doctora Laura Redman, presidente de la Sociedad Surafricana de Flebología, para este gran final del Saturday Night Vein Talk. Doctora Laura Redman.
Thank you. Let me just, okay. Sorry. Okay, thank you very much for this opportunity to present this case. I would like to present a challenging case on lymphedema. I'm presenting a patient who initially presented to me in 2015. He was a 64-year-old male who presented with primary lymphedema. He had no family history, and at that time, he had already had 5 bouts of cellulitis. However, he was a very compliant patient, and he saw a lymphedema therapist regularly. He had his own lymphatic pumping machine. He did compression bandaging, and he wore compression garments. He was quite an active patient in the building industry and still working, although he did have ischemic heart disease, but it was well controlled, and he was otherwise well. The problem was that for the last 2 years, the limb had been unresponsive and unmanageable, and not responding to bandaging or treatment. So the impact on quality of life of lymphedema are all the listed ones, and in the long term can actually affect the overall health of the patient in terms of cardiovascular risk factors and psychological health in terms of depression. However, at this time in 2015, our patient had an issue with clothes, but his wife made the clothes for him and he managed shoes if they went above the ankle. He was still working. He didn't have any pain. However, he did have the cellulitis I explained. So there are a lot more knock-on effects to lymphedema, which only progress over time. And the management currently consists of non-surgical and surgical options. The non-surgical options are manual lymphatic drainage, compression garments, compression bandaging, or lymphatic pumping using a machine. And the surgical options are excisional procedures or microsurgery. So Dr. Hakam Brawson actually introduced power-assisted debulking liposuction. And I'm going to speak a little bit about him before I come back to our patient, because it was under training with him is how I ended up managing this patient. So Hakam Brawson is from Malmö, Sweden, and he pioneered a lot about lymphedema. He added liposuction to the surgical options. So if we look at the surgical options that were or are available, it was this gross debulking or resectional surgery, which is not currently done because it was not very successful. Patients will get lymphoseals and aesthetically it's terrible, as you can see. In terms of the microsurgical techniques as well, although in some, if they stay patent, they may help the limb condition, they do not reduce the limb volume, and up to 50% can block within a year. So one of his earlier papers showed that whether a microsurgical anastomosis remained patent or blocked, there was no significant difference in limb size, and this is what really has the effect on the patient. He then started to look at what's really going on in lymphedema, and he found that it's associated with excess adipose and muscle tissue. But was there any evidence for adipose and lymphedema? And he's done about 30 years of work in identifying this and in how to treat it. However, it's taken very long to be accepted. So what is lymphedema? Is it lymph fluid that becomes fibrotic? Is it fat? Or is it a combination of both? And this is where all his initial work actually went, and I won't go into it now, it's just an overview to prove that there is adipose tissue in patients with lymphedema, and he proved this surgically as well when he aspirated it. So in the last decade or so, there's been an exponential increase in understanding of the lymphatics, and the fact that lymph makes you fat has recently been introduced. There's something called an adipogenic factor in lymphatic fluid, which stimulates the adipocytes in adipose tissue to formulate stem cells. More than likely, it's a protective effect. However, no one knows yet what this adipogenic factor is. Inflammation and free fatty acids have both been proposed. These result, though, in adipose tissue, which is not normal as it becomes fibrotic. So he devised a whole goal. If a patient has lymphedema and there's pitting, there's fat and there's fluid, decongestive bandaging will remove the fluid and one is left with fat, where debulking liposuction can land in complete reduction of the limb. And this is what his surgical idea is about. So this is practically how it's done in his clinic. A patient will undergo decongestive bandaging preoperatively to remove all the fluid that's possible. They will then, once there's only fat in that arm, they will be placed onto his program, which will determine what excess volume there is in that arm compared to the normal arm or leg. And then they're taken to theatre, knowing what excess volume needs to be removed. The patient is put under general anesthetic and the surgery is done under tourniquet to create a bloodless field, because it's a massive amount of liposuction and a huge volume being removed. So circumferential all the way until under the tourniquet to mesent anesthesia. And it's an operation that's done by feel, as the feel of the lymphodematous tissue is not like the normal leg. He keeps the fat post-op as well to prove that he's just removing pure fat. This is below tourniquet and this is in tourniquet, and he'll remove the tumescent fluid that he's taken out, that is, infiltrated. So liposuction works well on legs as well as arms as well. This picture is just of a limb of his, and he has many. And the importance here is that it actually has a long-term effect. So it can be maintained, but in order to do this, the patient must be compliant with compression. And this was a comment from one of his first patients, showing what a huge impact on the quality of life it has. And I've realized what worthwhile surgery it actually is. The question did arise, won't the lymphatics be damaged in doing this? If it's primary, well, we don't really have a cause, and a lot of the time they're not there, so does that really matter? But he went ahead and did the studies, especially for secondary lymphedema, and he found that no, there's no further impairment of the already decreased lymph transport capacity. So he showed that excess adipose tissue can be removed by liposuction, but not by congestive decongestive therapy, compression pumping, or microsurgery. And the outcome of conservative therapy and microsurgery is therefore limited by the presence of the newly formed adipose tissue, which has to be removed in order to get a complete reduction. And it requires teamwork. So this is actually a slide from him. So I went in 2019 to his unit to learn his protocols and did surgeries with him. He does a lot of training with the strict protocols, and you have to go with a lymphedema therapist and have patients planned. So I came back to South Africa. We did our first patient in March 2020, actually on World Lymphedema Day. And she was a young girl who had had a melanoma and then lymph node groin dissection and got uncontrollable lymphedema. And we undertook the surgery. It took a long time, about 5 hours, as the new one was a large volume. She did well post-op, and the important key factors here are that they do get a lot of post-op swelling. So although in theatre we measure to match the size to try and get the volume off, and we're watching how much you're taking out, they do get massive post-op swelling. In a lower limb, this can take up to a year to resolve, and in the arm, up to 6 months. But after a year, her leg had gone down perfectly. She was exercising. She was wearing shoes after 8 years, and she had actually ran a marathon this year. So that vastly improved her quality of life. She had a vascular lymph node transfer, but this didn't reduce the limb size. So what happened to our patient I presented in the beginning? Well, that same year in 2020, we planned to do the debulking liposuction as well, but medical insurance wouldn't cover primary lymphedema. There was also COVID occurred, and we couldn't do elective surgery. And then the patient went to visit his grandchildren in Australia for a few months. So he was gone for a while. When he came back, however, he had a slightly worse impact on quality of life. He now had back issues. He still had the clothes and shoes. He was doing less exercise and had gained some weight. He wasn't depressed, but it definitely was affecting his general well-being. And now he had 2 more admissions with cellulitis, much more severe than before when he wasn't admitted, even causing some renal impairment. He also, however, came back with progressive arm swelling. So we performed a duplex Doppler as well as a CT venogram and lymphoscintigraphy to exclude any venous cause or extrinsic compression for the swelling. So it all came down to another primary lymphedema. So he had of an upper limb and lower limb. So then we thought we really have to try and do something to help this patient. An opportunity arose because the TV had read one of the arm patients. We had done a few of the liposuctions in the year from a cancer patient and wanted to film the surgery and know about the story. So we had asked our hospital if they would do this patient's case pro bono, as it would advertise with them, and they agreed. However, they wanted to do it in 1 month. And normally we take quite a few months to prepare these patients as a team. So we really had to work hard. But the most important thing is the patient's mentally prepared and is compliant with compression. So he was, so we're already at an advantage. The patient needs to be prepared to wear compression day and night for the rest of their lives to prevent lymphedema forming again. They also have to know it's not cosmetic, as the hands and feet, if they're involved, it doesn't always go down fully on them. That's more fibrotic than adipose tissue. And also the ankles and knees, wrists and elbows won't always regain their normal shape as compression has become differential. Then they need to be aware of the time for the post-op swelling to decrease. And we learned for primary lymphedema, it can take even up to 2 years because of the fibrosis. Very importantly, there needs to be no fluid when they're going into theatre. So they need intensive decongestive therapy for 2 weeks prior to surgery to remove all that fluid so that you're only removing adipose. And then they'll have their custom garments made, which for us, we can't get made here. They need to be imported. So they're very expensive, and then it takes time as well. So our lymphedema therapist did an excellent job with the decongestive therapy. This was his ankle beforehand, and the bandaging really got it down. As you can see, it decongested there. The surgery was exceptionally long and never expected it to be that difficult. It actually took us 8 hours because the lower limb was so fibrotic. So it was very difficult, and our two other surgeons assisting me. We didn't get all the volume we want. We wanted about 5 liters. We got a fair bit less than that, but a lot of it was due to fibrosis. On day 2, though, he already had some more post-op swelling, but you can see that there is improvement in the leg. He was still a post-op challenge in that he got some pressure sores from the garments, but these were managed well by my lymphedema therapist. And this is a month later. We do have a picture from this week still, which I don't have available, but he's improving each time we see him. So that is positive. So the challenges of this patient, or of lymphedema in general and management, is the expense of the garments. The patients are committing to these garments lifelong. They need to get them changed, and they're very, very expensive. Then again, compliancy to be in the garments day and day and night, especially in the heat, is a problem. Obesity can be an issue with these patients. If they become sedentary, they do less, the lymphedema gets worse, and it becomes a vicious cycle. This also makes surgery harder. And the later in life we do surgery, the more fibrosis, the harder it is as well. And then medical insurance is obviously a big issue for us, as it's not covered readily, but we are prepared to take it on. So in going forward, the focus actually should be on quality of life, and not only survival and secondary lymphedema, which is from cancers or lack of limb loss. So it's a bit of a shift in the thinking of medicine. And we really need more awareness. We need to promote prevention if patients have had axillary or groin node dissections. We need to promote surgical interventions because they have a huge impact on quality of life and health of the patients. And then grow with the international trends and research. And we here, and I'm sure it's elsewhere, need to work with medical insurance and make them aware that it is actually classified as a vascular malformation. Thank you.
Thank you, Dr. Redman. Very challenging case indeed. Dr. Lorena, please, would you please comment and introduce the next discussant? Unmute yourself, please.
Para nosotros es un placer presentar al Dr. Vinesh Padachachik, cirujano vascular certificado, líder cirujano vascular del Instituto Venoso de Sudáfrica. Un placer escuchar al Dr. Vinesh Padachachik.
Thank you. Thanks, Laura. It was a great presentation, and it's a great topic. I just have 2 questions. When do you decide it's time to operate on these patients? When do you decide it's time to now perform liposurgery and stop with the bandaging only?
So for that, there's no decision we actually make. It's more what the patient makes. So if it's affecting their quality of life or their musculoskeletal system or anything like that, they would normally come asking for it. And then they have to be prepared enough to do it. So there's no limb volume or complications. Those are all like more motivations to try and get it covered by medical insurance. But in essence, as soon as the limbs actually got lymphedema, they're eligible for it.
Okay. And in terms of compliance, pre-op, you do compression bandaging on these patients. How do you ensure that they're compliant? Because often, these patients are really not compliant. Do you admit them? Do you keep them in hospital?
So the compliance is a huge issue, but that's what's part of the pre-op preparation. So we definitely, and as actually Akam Brawson said, and we've mimicked the same thing, is we've got a team. So we've got a team of therapists and they do intense interaction and intervention with the patient on all levels on what they have to do, diet-wise, weight-wise, compression, everything, and preparing them for the long road ahead. So if you're doing decongestive therapy pre-op, they have about 10 days of daily bandaging, but they come in for it, but they're really prepared and they're willing. Most of them really want that surgery done anyway, so they get their mind around everything and do it.
Okay, thank you.
Lorena, please. Unmute yourself, Lorena. Unmute yourself.
Es para mí un placer presentar a la doctora Mariuxi Morales de Ecuador, especialista de la Universidad de Flebología y Linfología, miembro del staff de Cirugía y Angiología Vascular del Hospital Luis Bernaza de Guayaquil, Ecuador. Doctora Mariuxi Morales.
Could you run the recording, Khaled,
Hola, muy
please?
buenos días a todos. Muy buenos días a todos. ¿Me escuchan? Muy buenos días a todos. Les hablo desde Ecuador, en estos momentos desde Galápagos, las Islas Encantadas, por eso estamos desde el teléfono. Mis felicitaciones a Laura por la tan magnífica presentación y a todos quienes hacen este webinar semanal, LAT-AF, Latinoamérica y África, unidos por la ciencia. Es muy interesante que cada vez que tenemos un paciente con linfedema y llega a nuestra consulta, realmente es un reto para cada uno de nosotros como especialistas. Laura, mi pregunta o mi comentario va en base a esto. Cuando hacemos o se hace lipoaspiración en los pacientes, que ya es una técnica que lleva más de una década, que se va realizando para mejorar la calidad de vida de los pacientes, esta técnica va únicamente dirigida a los pacientes que ya no pueden colocarse prendas de vestir o que los dispositivos de compresión o la terapia compresiva realmente no funciona y hay una deformidad del miembro, o se la puede utilizar también en el paciente que requiere hacerlo desde antes, aún teniendo opciones no quirúrgicas. Bueno, muchísimas gracias por la oportunidad de estar con ustedes y felicitaciones nuevamente.
Thank you very much. A good question as well. So the option really for these patients to undergo surgery, they come wanting it if they've heard about it because they don't want to live with the limb. So I almost see it as the same as varicose vein surgery. You get the whole spectrum. So patients who are well controlled with compression garments or manual lymph drainage or anything like that, right until advanced disease with ulceration. And it's the same with uncontrollable lymphedema when it's affecting their spine, they can't walk, they're getting cellulitis. So you're treating it based on any of those parameters. A lot of them are actually functional, and most of them that come are functional. They can't live with the arm because it's painful or they can't move or they're complicated. So more like advanced venous disease in a way. And very few would come saying they just don't like the look of it. Usually the look is a secondary thing and it's already affecting their functionality. But there's no pure exclusion or inclusion because the minute it's bigger, it's already formed the lymphedema.
Listo, gracias.
Lorena, please go ahead.
Es nuestro placer presentar a la doctora Elena Goranova, cirujana vascular, presidente del BSP, Balkan Venous Forum, y representante de flebología dentro de la Sociedad de Vascular de Bulgaria. Consultan también del Centro Alexandrova y vamos a escuchar ahora su comentario.
Thank you. Good day, everyone. Thank you to Rashad and to Vasila to inviting me at this forum. It is my honor. Laura, congratulations for your brilliant presentation. Evidently, you have achieved a good result in this complicated case. When you mentioned operative intervention, you took me back 25 years ago when we also performed excisional operation a modo cerveau. However, they took a long convalescent period, about 30 days after the operation, and long intensive unit care staying, and we abandoned this method. Now let's focus on the liposuction. As evident from the lymphoscintigraphy shown in your presentation, the lymphatic vessel remain undamaged after the liposuction, and the suffering limb may recover the shape of the healthy leg, isn't it? Bearing in mind the small number of lymphatic vessels situated in the subcutaneous tissue in the lymphedema extremities, it seems unclear how this procedure did not affect the lymphatic drainage system. So my question is, how the extraction of fat tissue is possible in a set with edema, preserving the vessels? And the second question is, do you have provided a longest period of follow-up?
Okay, thank you. So this work is done, I mean, all the long work is done by Hakan Brawson. So he's got, I think, 30 years experience. So he's the one who actually did those studies on lymphoscintigraphy and the preservation of the lymphatic vessels. But related to that is the technique of liposuction, and that they won't do the normal aesthetic liposuction with cross-hatching, they'll only go longitudinally. And so he did the lymphoscintigraphy and showed it in that way. Also then on that note, I mean, that's obviously is a query, surely you damage something small. It's not significant on imaging from a study, but on the other hand, there is no option for those patients currently. And every single one who's had it has had an extreme benefit and quality of life if they're going to, maintain it. So unless we can actually get to fixing primary lymphedema or really getting anastomosis straight after surgery, I don't think there is another current option available for them.
Yes.
And sorry, what was the second question?
How long is your follow-up? For this patient or for other patients? This is my cat.
Oh, for us. So I've actually, because I've only started it, so we started last year and we've only done, he was our 4th patient. But we followed them up. Well, we get to know them so well pre-op. So most of them actually haven't been from our city. So we followed them up in our city for the first month. This patient with us now, we've seen actually every week until we want to get it a bit down with my lymphedema therapist. But the others we follow up telephonically, and they're all with their own therapists. So they really follow up with the lymphedema therapists.
Yeah, thank you. Thank you.
Lorena, please.
Es un gran placer para nosotros presentar hoy a la doctora Zoe Diol, miembro de la Junta Directiva de la Sociedad Americana de Linfático y Venoso. Además, director regional del Center of Vein Restoration en Detroit, Estados Unidos, y además también parte importante del ABLS, doctora Zoe Diol.
Thank you. Thank you for having me. And again, as everybody has stated, Dr. Redmond, that was an amazing case that you went to a lot of extremes to make that patient's life so much better. And we all appreciate all the work that you do. I wanted to make a comment about the case that you presented here was a case of primary lymphedema. And the definition in the United States, North America, of primary lymphedema versus secondary lymphedema is separated. And the insurance coverage, which you also mentioned is a challenge. is differentiated here in North America between primary lymphedema and all other causes of lymphedema, such as venous insufficiency, obesity, and the opportunities and treatments available to those patients differ. Now, Tony Gaspers may comment that recently the American Venous Forum has classified that any C3 through C6 patient with edema is lymphedema, and that is helping us change this definition. And also in a post-COVID world, with the incidence of obesity rising due to quarantine, work from home, and also the incidence of venous thrombosis from COVID infection and post-thrombotic syndrome will be on the rise. So we will be seeing these secondary causes of lymphedema also rise. And getting proper treatment and proper definition and research is important. So we appreciate the work that you do. You had a very good suggestion for the primary lymphedema, trying to classify that as a vascular malformation. I think that was very brilliant on your part. But I think we need help working together to try to stress the importance of all these other categories of lymphedema so our patients can get offered the same types of treatment. I wanted to mention or ask you about medications used in this patient, the examples that you gave. As far as an adjunctive treatment, do you have any specific medications that you use, such as the microionized purified flavonoid fraction? And also a question about the outcome measurements, your measurements of the limb sizes pre and post treatment. They done by manual tape measure. Do you use a device, a 3D imaging device, such as the Lymphatic handheld device? I know there is currently a project that's being funded worldwide by the US side International Development and also the Bill and Melinda Gates Foundation. It's a 2-year project looking at the effects of medication on filarial lymphedema. And they're using that device to adequately measure outcomes. So I'm sorry, I threw a lot at you there, Dr. Redmond, but hopefully not too much in one jumbled up amount. I think you're muted, Dr. Redmond. I don't want to miss a word of what you're saying.
Thank you. Thank you for your questions and comments. Thank you. With regards to the medication, we don't routinely use it. I know for, the flavonoids and everything available are used more and more in venous surgery. And I think there's more work being done in lymphedema and lymphatics, but just, we haven't routinely actually used it, but it's something, that we may eventually actually start. We don't have a lot of the stuff in South Africa though. And in terms of that machine, I have heard about it and I think it looks great, and I know, but it's just a cost thing again. But we do need to measure, we put them into Hakan's program, so we measure every 4 centimeters, because intra-op, we actually keep measuring as we liposuctioning to constrict it and check we're matching the limb size all the way up. So it's because it's different circumferences. So that would be a useful tool. I don't have it. We'd still just have to measure for surgery, I think, but for the rest, it would be good. And post-operatively would be great, yeah.
Yeah, yes. Thank you. Thank you for that. And this is just, it was so educational for me to watch this as far as what you're liposuctioning out. And I have the same questions that other people have about how do we not damage the lymphatics? Is this something we just assumed that we did? This is all a learning experience. So thank you.
Thank you.
Thank you, Zoe. This was very interesting. And thank you for taking the time between your busy meetings to participate. Lorena, are there any questions in the Q&A box, please?
Es correcto, doctor. Y nos encanta poder tener esta pregunta del doctor Ahmed Nassef, donde, bueno, además, doctora, queremos manifestarle que hay muchísimos agradecimientos y felicitaciones, doctora Redmond, por su presentación. Y el doctor Nassef nos pregunta qué tanto es el reto con respecto a la anestesia en estos pacientes y si en alguna ocasión requieren cuidados en unidades de cuidado intensivo a nivel postoperatorio. Y bueno, se ha demostrado buenos resultados con compresión únicamente. ¿Cuál es su concepto con respecto a la compresión únicamente versus compresión y liposucción?
Thank you. Okay, so in terms of an anesthetic, we always use a general anesthetic because they're going to be under for a long time. Otherwise, the patients just risk assessed as they would be for any operation. So most of them are well patients, the young primary lymphedemas or the younger cancer patients. Some of them, of course, come with all their cardiovascular risk factors. So we get a pre-anesthetic assessment for that. Hakan brought, and actually most of his go straight to the ward. I put mine into high care post-op just because I'm starting and more cautious. And then on the second day, they'll go to the ward if everything's all right. In terms of compression, sorry, what was the question there? Compression and liposuction. We need compression as a non-surgical option, which is not going to reduce lymph volume. It's going to help with the lymphatic fluid. Liposuction, if it's done though, it removes the fatty fluid, but compression needs to be contained in order to remove the lymph fluid or to prevent it from forming again, and then the patient will get recurrent lymphedema. So they go into usually a class 2 and a class 3 compression post-op.
Any further comments, Lorena?
Es correcto, doctor. Tenemos otra pregunta del doctor Tobias Hirsch, en donde se refiere al uso de los wraps. Y él nos comenta cuál es su impresión con respecto a los wraps para poder dar un beneficio adicional. ¿Y hay alguna experiencia en conexión o en relación con la cirugía del linfedema?
Not with the surgery itself. They're just going to garments, and that's for ease because they're measured. So actually, we put those garments on intra-op. The wraps would be, I mean, they would be useful for somebody if they're fitted or measured pre-op, if they're not going to manage with the garment. For now, they're usually ordered and then they're sterilized and put on in theater, and then they're changed for the next few months as the leg gets smaller and smaller. I guess the same could be done for a wrap, but I think they would be a lot more costly. So I don't think any of us have used that post-op yet.
Thank you, Dr. Redman, for sharing with us this very interesting case. And thank you for sharing your technique, which is indeed very interesting and new to many of us. Thank you, Dr. Grelo, for moderating this case so nicely, and thank you for the discussion. And now it's really my great pleasure and honor to introduce my long-term friend and colleague, Dr. Wasila Taha, who will moderate the next part of this webinar. Please, Dr. Taha.
Thank you. Thank you so much, Dr. Rashad Bishara, for these nice words. And I cannot take the floor without congratulate Dr. Laura Redman for such challenging cases. Congratulations, Laura. And congratulations also, Lorena, for such a moderation beautifully as always. And the discussions were really fantastic. This segment was really high, and it does stimulate a lot of questions as we saw. And now it's my huge pleasure to moderate the second part of our night today. And the speaker will be a huge figure from Argentina, Doctora Mabel Busati. May I have the slide of Doctora Mabel, please, Dr. Rashad? Waiting for the slide of Doctora Mabel, I wish best to remind you that there are simultaneous translation for the English, Spanish, and French. Doctora Mabel Busati, she is from Argentina, as I mentioned, and she is coordinator lymphology sector and for the clinics of Hospital of Buenos Aires and past president of Argentinian College of Venous and Lymphatic Surgery and director of Neuromuscular Tapping Institute. In fact, she will deliver a very interesting topic about the relation and the correlation between the high body mass index, lymphedema, and lipedema. and we are really looking forward for her topic. Please, Dr. Mabel, we have a recording and she will be live with us for the discussion.
We cannot hear the English translation.
Open the microphone.
Khaled, please. Khaled, please, the audio is not running.
Una enfermedad crónica no transmisible de origen multifactorial que afecta el equilibrio neuroinmune metabólico y psicosocial de quienes la padecen. Su condición inflamatoria a partir del tejido adiposo disfuncional explica el nexo de sus comorbilidades. Manifestada por una alteración de la composición corporal caracterizada por un aumento del compartimento adiposo, siendo un problema común de prevalencia creciente que se define con el índice de masa corporal. Los hallazgos de la mayoría de estudios a largo plazo indican que el tiempo de vida de los pacientes con obesidad severa disminuye entre 5 y 20 años, dependiendo del sexo, franja etaria y comorbilidades que presentan. Entre las alteraciones orgánicas ligadas a la obesidad se encuentra el síndrome metabólico proinflamatorio, protrombótico, dislipemia, glucemia elevada, resistencia a la insulina, hipertensión arterial, apnea obstructiva del sueño, cardiopatías, cáncer, hígado graso, artritis, colecistopatías, derrames cerebrales, trastornos psicológicos y trastornos circulatorios. Es conocido que el aumento de la presión intraabdominal disminuye el retorno venoso, determina éxtasis venoso, aumento de la presión hidrostática en los miembros inferiores y todos los trastornos macrocirculatorios se transmiten a la microcirculación, determinando la aparición de lipodermatoesclerosis. Acelera la aparición de signos y síntomas de la enfermedad venosa y de la insuficiencia linfática. Múltiples estudios apoyan que el índice de masa corporal es un factor de riesgo importante en la gravedad clínica de la enfermedad venosa. Un estudio muy interesante de Catarina Garzón explica que las presiones más altas en reposo, en posición sentado y con el torso hacia adelante, crean más riesgos de úlcera venosa y que es una posición preferida por los pacientes obesos. Además, los trastornos osteoarticulares, el mal apoyo plantar, el dolor en las articulaciones y la ineficacia de las bombas musculares impulso aspirativas determinan limitación en la movilidad, lo que altera la dinámica venosa. Un estudio del año pasado sobre 440 pacientes realizados por Steve Dean determinó que la causa principal del linfedema secundario en Estados Unidos era la insuficiencia venosa crónica, afectando a 16 millones de personas. Un estudio de André Van Rij, australiano, sobre la compresión de la vena poplitea, la obesidad y la enfermedad venosa, nos refiere que muchos de los pacientes con obesidad que tienen alteraciones en la piel que infieren insuficiencia venosa crónica, en el estudio con ecodoppler no presentan ni reflujo ni obstrucción venosa. Estas alteraciones en la piel estarían dadas por la compresión de la vena poplitea, por la hiperextensión de la rodilla en bipedestación debido al aumento del tejido adiposo en el compartimento de la fosa poplitea. Además, cuando se instala la insuficiencia venosa crónica, sabemos que hay una insuficiencia linfática dinámica. Pero cuando esto se prolonga en el tiempo, este edema se transforma en crónico y hay alteración en los tejidos. linfedema y obesidad se asocia a un mal pronóstico en el tratamiento, acentuando el deterioro de la calidad de vida de nuestros pacientes. La acumulación de proteínas en el edema crónico provocado por la disfunción linfática es debido a la acumulación de ácido hialurónico en la piel, al incremento del compartimiento graso, a la fibrosis por los procesos inflamatorios, a la remodelación del colágeno, a la acumulación de fibrinógeno, fibrina y a las crisis inflamatorias e infecciones por déficit inmunológico. Oliver Guillermo, un investigador, identificó al factor plaquetario 4 como un biomarcador que podría utilizarse en el diagnóstico de la red vascular linfática y determinó que los niveles de este biomarcador se hallan elevados tanto en la enfermedad venosa como en el lipedema, en el linfedema y en la obesidad. Hay signos y síntomas que son comunes al lipedema, al linfedema, a la obesidad y a la insuficiencia venosa crónica, y otros signos que son distintivos y que nos permiten hacer el diagnóstico diferencial. Cuando el cuadro es florido, es fácil diferenciar un lipedema de un linfedema, pero en los estadios iniciales, muchas veces estas patologías son mal diagnosticadas o subdiagnosticadas. En el lipedema hay un aumento de los macrófagos que intervienen en los procesos inflamatorios. Y estos procesos inflamatorios determinan la dilatación de la microcirculación, la angiogénesis y la hipertrofia adipositaria. Y es importante tener en cuenta que las pacientes que padecen lipedema y obesidad, el tejido graso del lipedema es altamente resistente a la pérdida post-cirugía bariátrica y poco sensibles a las dietas habituales. Además, si bien sabemos que es poco frecuente las erisipelas en el lipedema, existen y hay casos donde la repetición de estas crisis infecciosas llevan a un cuadro más severo, que es el del linfedema, y es más difícil su tratamiento. La obesidad, como dijimos, es una epidemia mundial y en Argentina afecta al 49% de la población y el 14% corresponde a obesidad mórbida. Y esto aumenta la tasa de mortalidad en el 200%. Esta paciente fue recibida en el hospital de clínicas derivada de un centro de obesidad de la capital federal. El perímetro de su miembro inferior derecho ocupaba la camilla del hospital. Pudimos comenzar a atender a esta paciente aplicando el protocolo innovador en internación, y pudimos con un equipo interdisciplinario de apoyo realizar la higiene de la piel, las respiraciones abdominales, las aperturas ganglionares, los ejercicios miolinfoquinéticos y la compresión adecuada a cada fase del tratamiento, y a las 2 semanas del mismo pudimos ver la reducción de los perímetros, la movilidad de las articulaciones. En este caso utilizamos una combinación de vendaje multicapa y de dispositivos inelásticos autoajustables con velcro, y empezamos con el tratamiento de las 2 piernas bilateral, y a las 3 semanas de tratamiento estos son los resultados obtenidos poniendo de pie en movimiento a la paciente. Podemos verla aquí haciendo sus ejercicios miolinfoquinéticos. Les presento otro paciente atendido en el Hospital de Clínicas de 44 años, con un peso de 266 kilos y un índice de masa corporal de 78, que consulta por la imposibilidad de deambular debido al linfedema de miembro inferior izquierdo. Las bolsas linfedematosas le impedían la deambulación. Decidimos, pese a que no estaba en tratamiento por su obesidad, comenzar en forma ambulatoria el tratamiento del linfedema aplicando el protocolo innovador, y durante el tratamiento pudimos lograr la derivación a cirugía bariátrica, donde fue atendido en nuestro hospital por el equipo del doctor Ariel Ferraro y fue operado, por lo cual me limitaré simplemente a mostrar qué tratamiento médico realizamos nosotros previo a la cirugía. Aquí podemos observar la reducción de las bolsas linfedematosas y de los diámetros de la pierna, que es muy extensible la reducción, y podemos ver aquí a nuestro paciente realizando sus ejercicios personalizados. Y por último, para terminar, presentamos a la paciente Marina.
Tengo 44 años, tengo obesidad mórbida, la cual estoy tratando con el sector de cirugía bariátrica, vengo descendiendo 10 de peso y adicionalmente tengo linfedema en los dos miembros inferiores y tengo úlceras linfáticas, 5 para ser exactas, una se cerró.
Examen físico del miembro, la higiene de la piel y la curación de las úlceras que actualmente están en vías de cicatrización. Protegemos la piel sana con pasta al agua y procedemos a la colocación de la malla tubular de algodón y los 3 dispositivos inelásticos autoajustables con velcro, de pierna, rodilla y muslo. Y chequeamos la compresión deseada. Por último, Marina realiza los ejercicios miolinfokinéticos indicados.
Muchas gracias a todos por su atención.
All the thanks go to you, Dr. Mabel Bustati. It was really, really great and very insightful. And congratulations to deal with such extremely challenging patients. And now the time to fly all the way to North Africa for Tunisia. I have been in Tunisia in 2018. And when I asked who is the angiologist here, who is the phlebotomist here, I got just one answer. Dr. Jihan bin Sheikh. That's all, was all the answer. She is very, very famous in her region, in Tunisia and all the region. And Jihan bin Sheikh, she is member of so many societies, French, and even she is the founder of the founding member of the Tunisian Society of Vascular Medicine. Now we are going to her recording in French. So please pick up your language. And now the recording of Dr. Jihan, please.
Please run the recording, Khalid, in French. Khalid, please run the recording of Dr. Jihan. Dr. Wasila, let me do it. So please stop sharing and I'll do it.
Le bonsoir de Tunis. Ma question sera une remarque et une question à la fois. Donc, nous avons longtemps interdit à nos patients lymphodémateux la pratique d'une activité physique, surtout intense, en croyant que celle-ci, en augmentant le débit sanguin vers les membres inférieurs, aggraverait l'état des lymphatiques déjà altérés. Actuellement, l'exercice physique n'est plus interdit, mais plutôt recommandé. Et à ma connaissance, il n'existe pas de recommandation qui mentionne les modalités de cet exercice physique. Donc, je vous pose la question, est-ce qu'il existe des protocoles ou des modalités validées en termes de fréquence, de type, du temps qu'on doit mettre pour s'exercer chez les patients lymphodémateux, et est-ce qu'il existe des études qui ont mesuré objectivement l'efficacité sur le volume des membres, la qualité de vie et l'amplitude du mouvement du membre. Comme ça, nous pourrions au mieux conseiller nos patients lymphodémateux en espérant pouvoir un jour avoir un consensus précis. Et je vais rajouter une toute petite question. Est-ce qu'il y a des sports qui sont interdits, qui sont carrément interdits chez les patients lymphodémateux? Je vous remercie.
Thank you, Dr. Jian. Dr. Wasila, could you please translate the question into English?
Yeah, yes, Dr. Rashad. Just very briefly, Dr. Jihan Ben Sheikh, she was asking about if there is any consensus or precise protocol to do physical activity, because it was not in the past not recommended to do physical activity in such patients, and now she wants to know if there is precise consensus for this. Her second short question was about if there are some sports or some physical activities which are avoided or forbidden or not allowed for those patients. These were the two short questions of Dr. Jihan Ben Sheikh. And now, Dr. Mabel, the floor is yours now for answering.
Bueno, muchísimas gracias. Buenas tardes a todos. Quiero agradecer al doctor Rashad Bishara, al comité organizador y ejecutivo de LAT-AF, la invitación a participar de este relevante evento, y agradezco a la doctora Jihan la pregunta que me ha realizado. Como ella bien dijo, hay un antes y un después. Antes del año 2000 prohibíamos a los pacientes que muevan su miembro linfedematoso, que no hagan fuerza, que no hagan movimiento, que no carguen peso. Pero la situación ha cambiado, y gracias a Dios la Organización Mundial de la Salud habla que la actividad física es segura, protege contra las enfermedades crónicas, mejora el funcionamiento físico, recupera la fuerza, movimiento y función, mejorando la calidad de vida de nuestros pacientes. Recordemos que cuando tenemos un linfedema hay una disminución de la reabsorción del líquido por el capilar linfático y una disminución del transporte a través de la actividad reducida del linfangión, y el ejercicio físico es una de las causas externas que mejora esto, que aumenta el flujo linfático y aumenta la actividad del sistema. Por lo cual es muy importante la actividad física en nuestros pacientes. Y hay muchos trabajos y hay evidencias científicas que dicen que el ejercicio no aumenta el volumen en el linfedema, al contrario, lo reduce. Lo que sí aumenta es la fuerza muscular, la masa muscular, mejora el rango de movimiento y mejora la calidad de vida de los pacientes, obviamente. En cuanto al deporte, por supuesto que el ejercicio físico debe ser planificado y dosificado de acuerdo a cada paciente. No hay una regla para todo, no podemos decir un linfedema grado 2, un linfedema grado 3, este es el protocolo de ejercicio que vamos a tener, porque no solo va a depender del estadio y de la presentación de la enfermedad, sino también de la capacidad de cada paciente, de las comorbilidades, de las distintas afecciones que los pueden limitar funcionalmente, por lo cual hay que dosificar y planificar el ejercicio para cada paciente. Eso es importantísimo. Siempre todo plan de entrenamiento debe ser lento y progresivo y debe llevar un mínimo de 6 a 12 meses. En cuanto a los deportes, si el paciente que padece un linfedema anterior a la instalación de su enfermedad era deportista y realizaba algún deporte, nosotros Después de tratar el linfedema que el paciente tiene, debemos tratar de llevarlo a una situación donde el paciente pueda volver a realizar sus actividades habituales. Y si la actividad habitual de ese paciente era realizar un deporte, nuestro objetivo, en forma paulatina, como lo dije, dosificado y planificado, debemos llevarlo a la situación que pueda nuevamente realizar ese deporte. En realidad no hay deportes proscriptos si es que el paciente estaba entrenado para tal fin. No sé si he respondido la pregunta de la doctora.
Thank you. Thank you, Dr. Mabel. It's perfectly well illustrated and well informative. Thank you so much. And we will stay in Argentina. Still, we are in Argentina to introduce a huge figure and a leading figure, the next discussant, Professor Luis Marco Vecchio. The slide, please, Dr. Rashad, for yes. Professor Luis Marco Vecchio is a physician at Flebo Law Giant Lymphology Service, Central Military Hospital of Buenos Aires. He is the Vice President Director of the Argentine School of Lymphology for Graduates and a member of the Argentine Society of Lymphology and Lymphology. I would say that we have a recording from Professor Marcoviccio, please.
Ustedes a través de este virtual, en primer lugar quiero felicitar a la doctora Mabel por la excelente presentación acerca de los temas de obesidad, insuficiencia venosa y linfedema, una combinación muy interesante que ha abordado la doctora. Fue muy clara cuando mencionó los alcances de esta patología a nivel fisiopatológico, a nivel de los procesos metabólicos involucrados, y también quiero destacar cuando mencionó que acelera y agrava los signos y síntomas de la enfermedad venosa y linfática de estos pacientes. Y por supuesto que agrava la situación clínica de los mismos. Fue muy interesante también cuando mencionó cómo se limita la movilidad de estos pacientes, después los diagnósticos diferenciales que mencionó con respecto a lo que es linfedema, lipedema, flevedema, los cuadros mixtos, etc. Es importante también como ha mostrado los 3 casos clínicos que ha tratado junto con su equipo, con excelente evolución en estos pacientes muy complejos, con obesidades mórbidas, con linfedemas muy voluminosos y que los ha llevado adelante muy bien. La verdad que muy interesante su presentación y son situaciones muy complejas y podemos ver que se entra en una especie de un feedback, una retroalimentación, un círculo vicioso entre lo que son muchas opciones que influyen en forma negativa en los pacientes. Por ejemplo, tenemos la obesidad, la insuficiencia venosa y linfática, como bien mencionó la doctora, y todo esto trae aparejado también las alteraciones de la movilidad, alteraciones cutáneas, alteraciones también en lo que es la calidad de vida de estos pacientes, la aparición también de infecciones, como bien se ha mencionado. ¿Y qué es lo que ocurre con todo esto? Entramos en una combinación donde cada uno de estos elementos potencia y agrava la aparición de estos signos y síntomas de estas enfermedades. Es decir, necesitamos trabajar en forma integral, como bien mostró la doctora, en forma de equipo multidisciplinario y hacer un abordaje integral y total de esta enfermedad, incluyendo, como decía, como bien dijo la doctora también, no solo la obesidad, sino la parte venosa, linfática, la movilidad, el estado de la piel, también los ejercicios, el tratamiento con equipo, los elementos fisiátricos, kinésicos que cada uno disponga, todo apuntando a mejorar la calidad de vida de los pacientes. Desde ya agradezco mucho esta posibilidad, muy honrado de poder dar una breve y una opinión con respecto a esta excelente disertación del doctor Augusto. Agradezco al doctor Rashad Villara, como así también a todo el comité organizador del LAT-AF, y la verdad que muy honrado, como le decía, y mi saludo cordial para todos los que están conectados, colegas y demás asistentes a este congreso. Muchas gracias. Hasta pronto.
Thank you so much for you, Louis. It has been a great and huge honor having you among us this night. Thank you. Dr. Amabella Busacci would like to comment on the comment of Dr. Louis. What do you think?
Sí, bueno, primero agradecerle al doctor Luis Marcovecchi, un referente de Argentina, para nosotros muy importante, un gran amigo y colega estudioso de las enfermedades linfáticas y venosas. Así que estoy muy agradecida por sus comentarios.
Okay, thank you, Professor Busacci. Thank you, Professor Marcovecchi. Thank you so much. And now we will fly all the way to Holland, to Netherlands. And I can say that this is our luck today, because Dr. Marald Wickling, a huge figure from Holland, and he was so generous with a very short notice, and he did join us just maybe a couple of hours before we go online. Thank you so much, Professor Wickling. And Marald Wickling, as I mentioned, from Holland, he is a vascular and lymphedema surgeon, Hulkendien, Fraxland, and location MCL and Niche Smelling Hospital. I wish that I pronounce well. And Professor Wickling is going to deliver the European perspective on our topic tonight. Professor Wickling, the floor is yours now, please. You are going live. Okay, perfect. Yes, we can go. Yes, please. Please,
yes, thank you so much. Yes, I'm going there. One moment. Let's get in there. Okay. Everybody can see my presentation. Yes, please say yes.
Perfectly well, Marald. Yes, you can go.
Okay, thank you so much for this kind invitation and short notice, no problem. Also, on behalf of my co-workers, colleague Klinkert and Witte, I'd like to present this. So it's a very nice initiative. I have never heard about this, but it's a really, really great session. So all the speakers congratulate you. I have no inflict of contrast. I work for a consultant as Boston Scientific, Binary Director, Medtronic and WL Gore, but not for this talk. Actually, during the COVID epidemic, the epidemic of lymphedema was more or less underwater. So everybody was staying home, staying safe, talking about COVID, but there's also another epidemic. And I was asked to talk very shortly, only 2 minutes, so I will hurry up. I'm from the Lymphedema Center in Drachten, the Netherlands, and we publish lots of national, international literature of our circumference-assisted lipectomy, like the previous speaker also talked about. We published in 2009 about the arms, in 2017 about 47 consecutive patients with legs.
Sorry, Dr. Marald, but we cannot see your presentation. We cannot see your presentation.
You cannot see my presentation. Okay.
Share your screen, yes, please. Share your screen.
Then we go again. That's the one. Share. Otherwise, we'll go back to the one you recorded as well. But here we go. I hope
because we are short of time, can you make a brief comment, please?
Oh, here we go. So now here we go again. No worries. Hop. So actually, there are 2 great papers about the healthcare epidemic about lymphedema. You can show in the picture, and it's a big problem, not only in the European countries, but also worldwide. And a lot of people suffering this from primary, but also like secondary, like in Egypt for filariasis. And if you look at a map, you can see that the more is known about in a country, the more tertiary surface there are, and people can actually treat them at our place. If you had to talk about treatment stages, there are actually several treatment stages. You can talk about bandages, decongestion therapy, practice, skin tear, all the way up to operation in an expert center like ours in the Netherlands. During the COVID epidemic, there actually were problems for weight control, self-activeness, and operation in expert centers, because expert centers were only for emergency cases like ruptured aneurysms and not for lymphedema. So all these patients had to wait for 1 or 2 years during the COVID epidemic. And this is actually a very big point. So there are a lot of patients and they're underwater. And during the COVID epidemic, the awareness has subsided also for the patient, but also for the healthcare professionals. And treatment has gone actually abandoned. We haven't done that much operations last 2 years, only 3, instead of the 20 we do yearly. So this is a very big problem. And I want to thank you for this. And if there are any questions, I'd like to take them. So I'm sorry for the technical hiccups.
No, not at all. Thank you so much, Marel. It was really great having you with us this night. And now we go to the questions and answers. And we do have a question from Africa and another one from Spain. From Africa by a huge figure, a lymphatic therapist, Dr. Eva Magdi, and she is asking about the patient with lymphedema after liposuction. What is the best degree of compression for the custom-made garment post-operative? Would you like to answer, Dr. Mabel Busati? Dr. Mabel Busati, please.
Sí, bueno, voy a contestar la pregunta. Las compresiones altas, inelásticas, con tejido plano son las más óptimas, aunque nosotros no hacemos liposucción, conocemos la técnica, o sea, la liposucción lo que trata es la complicación adiposa del linfedema, y las recomendaciones en la compresión posterior a la liposucción son altas compresiones, de más de 30 milímetros de mercurio.
Okay, thank you, Doctora Mabel. And now another question in Spanish from Doctora Maria Angelica. She is asking about the guidelines. What are the guidelines in lymphedema and active cancer in terms of compression, drainage, and medication? And she is also congratulating you, Mabel.
No entiendo bien la pregunta, si podemos ampliarla. Bueno, muchísimas gracias, María Angélica. Bueno, ante una paciente con linfedema y un cáncer activo, prima la parte oncológica, ¿no es cierto? El oncólogo es el que debe tomar la guía del equipo médico y comenzar con la terapia que esté indicada, sea quimioterapia, radioterapia, y una vez nosotros acompañar todo ese lineamiento que el oncólogo va a marcar el paso, ¿no es cierto? Quizás ante un cáncer activo tenemos que manejarnos con lo que llamamos cuidados paliativos, pero todos trabajando en un mismo equipo, pero en el tema de cáncer activo lidera el oncólogo el tratamiento del paciente.
Thank you so much, Dr. Busati. And now we fly all the way to North America, to Canada, for the leading figure there and the huge figure in phlebology. One, she doesn't need any introduction, actually. Professor Pauline Raymond-Martinbout, past president of the Canadian Society of Phlebology, and a very good friend and very supportive to our society, IVLA. Thank you, Pauline, so much. Having you with us this night, it means a lot to us. You wish to go live, or we can play your recording as you wish, Pauline. What do you think?
Unmute yourself, Pauline. Unmute, please. Unmute.
Yes, thank you very much, Wasila, and thank you, Dr. Bishara and the committee for giving me the opportunity to discuss practically what we would do for a chronic venous disease and patient with large limb. I will let you go with the pre-recorded if it's not a problem. If not, I can do it live.
Better you do it live, please.
Okay, but I have to have some slides.
Oh, all right. So I'll do the recording. All right.
Hello, everyone. I'm Pauline Raymond Martinville. And first, I'd like to congratulate Dr. Bissetti for her excellent presentation on hyperobesity and phlebitic lymphedema. Thank you for allowing me to give a short Canadian perspective on this problem. Complex higher obesity and phlebitic lymphedema occur when the patient has additional and related disease. Mabel described very well the many factors which contribute to the development of these conditions. As such, multi-component interventions are required to address these myriad factors. When patients are well controlled and they have the desire to be treated for chronic venous disease, challenges are meant to be overcome. In Canada, because of the health system, physicians are more prone to use sclerotherapy for outpatient. It is cost effective and is less risky than some other procedures. The disadvantages is that there are limitations in diagnosis and vein access, and it needs a special ultrasound equipment. And of course, it needs more proficiency and expertise from the treating physician. Equipment, image, patient itself, needle are the challenges. In addition to the risk of structural anomalies, there are technical challenges. Many factors contribute to suboptimal imaging in patients with higher BMI. The depth of the body fat layer, the depth of inflammation, the absorption of energy by the adipose tissue, and the higher back
What's happening? I'm sorry.
Connection.
Yeah.
I'm not sure, but it's not running.
It looks like it is put on pause, but so let me make some live comments.
Yeah, just go ahead and make some comments.
Okay, so when we perform injection for chronic venous disease, especially for the saphenofemoral junction, it is important to prepare the patient prior to the treatment. Make sure the patient is well hydrated and the patient is put the compression regimen before the treatment. We would use a curvilinear probe, and we would use a low frequency probe, which we can use even a probe as low as 1 megahertz. We also sometimes use the harmonic imaging, and this is very helpful. On some equipment, you can find some software that will enhance the needle for the injection. And then there's also on the market some echogenic needles that are longer, and they do have some dimples. And also you can use your ultrasound equipment to color the needle with a device that will vibrate the needle. These needles are very long, and of course they're safe because they are colored. They pick the color. So despite all, of course, the sonographic tips and tricks that you can give to perform a very deep injection on patients with high obesity and phlebitic lymphedema, it is still quite a great challenge. And of course, there's limitations. Now, only physicians with a lot of expertise would be able to treat that kind of patients. In the future, we may have some different drug delivery options, or even MRI guided injection in open bore could certainly help for some very complex patient. Thank you for giving me the opportunity to discuss an approach with sclerotherapy to treat the patient with a very, very large limp.
All the thanks go to you, Pauline, for this insightful and very important and valuable contribution and information about how to do sclerotherapy in patients with high body mass index. Thank you, Pauline. As always, brilliant. Thank you so much, Pauline. Huge honor having you.
And thank you, Dr. Bishara.
Thank you. Thank you very much for joining us.
And now, Dr. Rashad, please.
It's my great pleasure to introduce Professor Antonios Gasparis, who is president of the American Venous Forum, and he's going to give us the American Venous Forum perspective on lymphedema. Please go ahead.
Thank you, Dr. Bishara and Mosila, for the invitation. That picture there is about 10 years old, so, you know, I just turned 50, so we got to be careful updating. Don't want to, you know, project things that are not true. But I have to say, I am very humble to be invited here to represent the American Venous Forum among really experts in the field of lymphedema. I will have to say I would not consider myself an expert in the area, although I do have developed a strong interest in the last few years. Now, I want to congratulate Dr. Busari for really an excellent presentation. And we all know that lymphedema, you know, is characterized by edema, fibrosis, and abnormal deposition of adipose tissue, as Laura mentioned in her talk. And really, in managing these patients, it's you got to address not just the edema part, but also what can you do for the adipose deposition, if anything. Now, the knowledge is expanding between the relationship of obesity and lymphedema, but the real problem here, in my mind, is obesity. You know, I'm a simple guy, and I like to think simple because that's how you find sometimes solutions. And I think we still have a lot of unknown answers on how to really manage these patients. But the obvious thing to me is that obesity has reached, you know, epidemic proportions, actually tripled in the world over the last 40 years. And this is really what's contributing to not only increased incidence of chronic venous disease in these patients and the typical leg that looks like a CVD patient, but really sometimes doesn't even have underlying venous disease. It's due to the venous obstruction from the increased intra-abdominal pressure, which is probably also contributing to the obstruction of the lymphatics. So you have all these multifactorial things, whether it's increased abdominal pressure, whether it's calf muscle dysfunction, but the bottom line is obesity. And the lymphedema-associated obesity is just a side effect of what we see in these patients, that they have increased diabetes, increased coronary disease. You see a shift in the demographics of these patients. So unlike the typical lymphedema patient, which is more common in, you know, females, now you start seeing in this specific morbid obesity population, the lymphedema is higher or incidence in males, or increased compared to the non-obese patients. And my thinking is, you know, if we're gonna, you know, move forward in the field, you know, we can put a Band-Aid on things and try to fix maybe the underlying vein problem, or try to do, you know, control the edema with different, you know, the typical lymphedema therapy. But the main problem in these patients is the obesity. And unless you address that, you're just putting a Band-Aid on what really is going on. So I want to really thank everybody for the invitation, and I really learned a lot.
Thank you. Thank you for joining us, and thank you for your comment and your insight. Thank you very much. And now, again, it's my great pleasure to introduce Dr. Kathleen Gibson, who is member of the board of directors of the American Venous Lymphatic Society. She couldn't join, and here's her recording.
Hi, I would like to thank the organizers of the meeting for inviting me to give an AVLS commentary on Dr. Mabel Busari's excellent presentation about obesity, venous insufficiency, lymphedema, and lipedema. And the comment that I have from the ABLS perspective is the issue of morbid obesity and the impact on quality of life of patients is not unique to South and Central America and not unique throughout the world. This is an area in the United States that we also have this epidemic of morbid obesity. And as mentioned in Dr. Busati's talk, there's multiple reasons why morbid obesity affects the lower extremities, including increased central venous pressure, the positioning of the patient in a sitting position, as morbidly obese patients often like to be, and dysfunction of the calf muscle pump. As morbidly obese people do not have good range of motion in their calf, and they often have a stiff Achilles. So these things all add up to causing problems with venous insufficiency and ulcers in the leg, despite the fact that some of these patients have no reflux. And if you study them, they have no venous obstruction that is structural. What they have is one that is from the obesity and the pressure that's transmitted into the legs. We saw an excellent depiction of differences between lip edema and lymphedema and some truly impressive pictures of management. So these patients are truly challenging. Multidisciplinary approach is necessary. Recognition of the different presentations of morbid obesity in terms of how they affect the lower extremity is also critical. So I would like to again applaud Dr. Busati on her excellent presentation. I don't have any disagreements with anything that she said, and feel again that this is a global issue, that unless we kind of tackle some of the root causes of morbid obesity, is going to continue to present a challenge for us all. So thank you again, and congratulations on the excellent session.
Thank you, Dr. Gibson. And now it's really my great pleasure and honor to introduce a very well-known professor in the field of the veins and lymphatics, Dr. Thomas Urbanek of Poland. He's a consultant vascular surgeon. He's president of the Polish Society of Lipology. He's member of the European Venous Forum and member of the American Venous Lymphatic Society. He's member of the organizing committee of the European Venous Forum, HOW and PLUS, a very efficient committee indeed. And he was the president of the URP chapter of 2019. Many of us enjoyed it. He's going to talk to us about a very interesting topic and very practical and important in our day-to-day life. When am I using and when am I not using venoactive drugs? Please, Professor Urbanek, go ahead.
Thank you very much for giving me this opportunity. The topic about the venoactive drugs in the most of the events is probably not that the most people attend, but let's try to be more practical on this. Once again, thank you for invitation. So let's try to answer the question when to use and when we should probably not use the venoactive drugs. We know that chronic venous disease, it's a variety of clinical pictures, but the question is, should we use venoactive drugs in these patients, or should we use perhaps and book the medical treatment for such a pathology? We know that chronic venous disease, it's a quite complex situation. It's with symptoms, signs, venous hypertension, and also pathology in large and small vessels. Many of these things related to inflammation, which seems to play a crucial role in the pathogenesis, but also in the changes which develops at the skin and soft tissue level. So probably most of you will recognize the severe inflammation in this patient. Probably you will also see this inflammation in the skin and subcutaneous tissue in these patients, also in this liposuction dermatosclerosis and swelling patients. We can think about the advanced inflammatory process. So let's try to find the place for venoactive drugs in armamentarium of the methods that we have for the chronic venous disease treatment. We know that combined treatment, like this case, surgery plus compression, can reverse many things. It can look better, but as we can see, probably also the inflammatory process can be at least slowed down, if not stopped in many patients. Here, we see the huge inflammation around the venous lake ulcer in patients with venous vein incompetence and local skin changes. And this is after the treatment based on endovenous laser treatment, sclerotherapy, compression, and also medical treatment. So we have the quite well-specified therapeutic goal which we would like to achieve. So when do I use VEN-active drugs? As we can find in the guidelines, and I try to follow also this, of course, none of the patients are the same as the other patients. We should use the VEN-active drugs to relieve chronic venous disease-related symptoms and swelling in patients at any stage of disease. This was written by Professor Nicolaides and the group in the 2018 guidelines. We know that there's a huge number of symptomatic patients in a bone vein study in Germany. Probably half of the population was symptomatic with symptoms of chronic venous disease. And we know that both these patients, this is C1S, C1 symptomatic and C4 symptomatic, can have the symptoms. We also can have patients which are C1 and more symptomatic than the patient with C4 or even C5 pathology. What about C0 symptomatic? Because we also see these patients. It's also the significant number of the patient, because in the Edinburgh study in Scotland, C0S was a quite big number of patients, and there are the recent data from Vein Consult program, where among the whole group of the patients with chronic venous disease, symptomatic patients with C0 was around 20% of the entire population examined in this study, and C1 we can expect in C1 symptomatic can be also found in significant number of the patients. But to summarize this knowledge, we know that we can have patients without the signs of the chronic venous disease, but with the significant problems related to the symptomatic course of the disease. We also know that the symptoms not always correlate with the signs of the disease, and we have some patients with, as I mentioned, severe stage and significant signs which will be asymptomatic, and also this can be the reverse situation. C1 and C2 pathology can be very symptomatic. Should we use the drugs for the disease progression? Of course, if we look into the studies, we will find several links which can be potentially from the clinical point of view important, but we do not have any scientific proof that any of the drugs which work for the disease progression. This has to be verified in the clinical settings. Pharmacotherapy can be used as the isolated treatment and can be used as a combined treatment of chronic venous disease, but probably we should not use this instead of, for example, invasive treatment. So if we have patient for the varicose vein surgery, we should probably go in the direction of doing the surgery and then give just the tablets, give the medical treatment. We should also use other ways of the treatment, and here are the recent guidelines on medical compression stocking chronic venous disease. We know that there is the place for medical compression stocking to improve the symptoms of chronic venous disease, to improve the quality of life and venous symptom severity, as well as to reduce leg swelling. So the next question, do I use pharmacotherapy as a part of combined treatment of chronic venous disease patient? Yes, together with compression. For example, I use this in the patient which remains symptomatic, in the patient with swelling and symptoms despite the compression treatment, in the patients when the patient does not correlate the strong compression. And of course, most of you are also from the countries where in the hot climate, using the compression, especially outside, will be quite difficult. So in Poland, this will be the summer months, but probably in other parts of the world more often. And venous leg ulcer patients is also the part of the combined treatment of this pathology. Together with invasive treatment, we do not have many data suggesting that we should do the medical treatment together with invasive treatment during the operation and immediately after. The evidence is very, very poor. But in my opinion, we should continue the pharmacological treatment if the patient remains symptomatic after varicose veins removal and after any invasive procedure, which we do on this patient. Some other indications, we know that some drugs can improve the results of the treatment. And here is the example of the study with sulodexide. And the study was focused on the hyperpigmentation occurrence in the patient undergoing sclerotherapy. So 3 months treatment with sulodexide significantly reduced the hyperpigmentation rate in the patient undergoing sclerotherapy. This study comes from Mexico and was already published in GVS, venous and lymphatic disorders. When I will not use venoactive drugs, asymptomatic patients with varicose veins, telangiectasias, or reticular veins, it's not the good candidate for using medical treatment. Patient which gets the optimal control of swelling and the symptoms by the means of medical compression, we should not use, as I mentioned, instead of the invasive treatment. And of course, the cases with the adverse events related to pharmacotherapy. Another important question, which drug should we use? We have the several groups of the drugs, which you probably know very well, and many of you use them in a daily practice, but the current approach which should be probably based on both, on individual evaluation of disease severity and symptoms presented, and also individual approach to the drug efficacy on the individual symptoms and signs present in the particular patients. And for example, if you go this way and look into the drugs which we probably most commonly use, like MPFF, we know that for pain, heaviness, and feeling of swelling, we have high level of evidence that this drug works probably very well. For the other symptoms, the level of the evidence is not as high as for pain, heaviness, and sensation of swelling. Hydroxyletolrutosides, the level of evidence is moderate for 3 of them: pain, heaviness, cramp severity. Ruscus extract, usually given in with the 2 other compounds together. Level of evidence high for pain, heaviness, feeling of swelling, but moderate for tiredness, cramps, and pruritus, and also high level of evidence for the ankle circumference reduction, and also high level of evidence if we speak about the horse chestnut seed extract for pain, pruritus, and edema reduction. So we probably don't need to remember this all, but looking into the literature, we can find the level of recommendation for some particular symptoms, and also in the case of some of the drugs, also signs, which will be the level 1 of recommendation to use these drugs in this particular complaints. And we should rather focus what kind of complaints is a patient reporting, and which drug should we adjust to this, what the patient reports. And here in red, you have level 1 of recommendations in this most commonly used drugs and particular symptoms mentioned. Other than active drugs, we can mention at least 1 more important drug, which is sulodexide with a pleiotropic effect. This is a mixture of glucose aminoglycans. From 2017, we can speak about this drug as about the venoactive drugs, because Joe Raffetto and his team discovered that this drug can have also vein contraction abilities, which is one of the typical activities of the venoactive drugs. We know that sulodexide reduced the swelling, as we saw also in other drugs like MPFF or Ruscus extract. We know also that sulodexide can influence on the symptoms severity regarding heaviness, pain, cramps, or paresthesia. And one of the last question, how to treat the venous leg ulcer. We know that the treatment is also combined mostly based on the compression, but pharmacological treatment seems to play also an important role. However, should be used in addition to compression therapy. And we have 3 drugs with the high level of evidence. It's MPFF, pentoxifilin, and sulodexide in this clinical scenario. Something about the skin changes, can we reverse them? At least partially, this can be done with the compression. And even if we do not have the good randomized control studies, we know that using the medical compression, we can improve the skin changes, and also improve lipodermatosclerosis in the patient with chronic venous disease. And we have also some evidence regarding at least some of the drugs like MPFF, regarding like redness reduction and skin changes reduction, which comes also from the evidence and was emphasized in the guidelines, which I mentioned. The same effect, lipodermatosclerosis reduction, as we saw with MPFF, can we probably achieve with other drugs like sulodexide. And here is the treatment comparing both treatments, so standard treatment and adding this medical treatment with sulodexide. As this drug we use quite often, there is important question, are they really always successful? And the question is no, they are not always successful. And this is number needed to treat, for example, MPFF, Ruscus, oxyrutin, to get pain relief. So we need to give this drug to almost 5 patients to get pain relief with MPFF and Ruscus. To get the heaviness relief, from 2 to 3 patients who should receive this 2 compounds. So we should not count that always will be successful, but at least in some patients will get the relief of these symptoms. Thank you very much for your attention. And once again, thank you for invitation.
Thank you, Professor Openek. That's very interesting indeed. It's an important topic that's interesting to all of us. And I think we can summarize your lecture in 2 key words. The first key word is symptoms. These drugs are used for symptomatic relief, essentially, in addition for treatment of hyperpigmentation and venous leg ulcers. And the second key word is that they cannot be used in place of definitive treatment, invasive treatment, etc. Thank you very much. And now I will go to the discussants. Our first discussant is Dr. Ahmed Hassan Bakr, who is from Egypt. He's a lecturer of vascular surgery in Asyut University, one of our major universities, and he's also associate member of EVLA. He cannot be with us, and here is
dear professors and colleagues. Dr. Rashad, thank you for including me in your discussion. Dr. Tomas, thanks for the fantastic presentation and a great summary as regarding the use of lipotonics in management of chronic venous disease. Certainly, the better understanding of venous pathophysiology created important pharmacological targets. However, the current literature, including systematic reviews like the Cochrane one by Martinez et al. And other similar studies, usually concluded with a little disappointing message as regarding the grade of evidence. Anyhow, I congratulate you as you managed to pick a very consistent message from all those studies regarding a clear indication for their use in NEC whenever there are symptoms like heaviness or pain, and a clear non-preference in case of effective compression therapy or to replace an important effective invasive treatment or with the occurrence of adverse side effects. My questions are regarding special situations. First, the use of sulodexide in the perioperative period, and I'm pointing to their anticoagulant effect. Does this impact results as regarding ecchymosis and postoperative pain? And the second, patients with mixed venous ulcer and an ankle brachial index of 0.5 to 0.8, non-option, I can't reconstruct these arteries. How do you see the phlebotomic drug and their effect in such cases? Thank you very much.
So if you allow me to summarize his questions, what's the role of sulodexide in improving results of invasive treatment? And the second question is there a role for venoactive drugs or other drugs in venous leg ulcers of mixed pathology? Mixed means venous and arterial.
Thank you very much for this question. The first one concerning sulodexide and invasive treatment, in reality, we have just one study on hyperpigmentations, but this study opens new possibilities, and I hope that there will be new study coming in this field. I am not aware about any other studies with sulodexide concerning the invasive treatment, so just hyperpigmentations, but in some patients we'll continue the drug or the other venotonic drugs if the patient remains symptomatic. Regarding the second question, if we have the mixed ulcer, we know that for the patients with, for example, ulcer, which is of the mixed pathology like venous and arterial, or venous and especially diabetic, we have also studies concerning sulodexide that it seems to be very efficient option of treatment. Of course, the groups analyzed in the studies concerning the mixed pathologies are much smaller, and we do not have very good randomized control studies concerning this. So I see the space for using sulodexide in the mixed ulcer, especially in the patients with venous and diabetic pathology. Regarding the arterial pathology, we know that if we speak about the patient with critical ischemia, we should rather look for the revascularization possibilities.
Thank you. Dr. Zoe, you have a comment? Go ahead, please.
I do. On the Solotic side, there was a really good article to read about its use in regenerating the glycocalyx, using the side stream dark field imaging on non-diabetic and diabetic patients. Using Solotic side, you can see a definite increase in the thickness of the glycocalyx on the patients, which will then help reduce edema and improve wound healing on ulcer patients. That's just one study that I'm aware of, but it was very promising.
I am aware about several studies in diabetes, and there are studies focusing on diabetic microangiopathy. And this is what you said, but it's confirmed also in other studies, also in some in vitro experiments. But looking for the clinical model with randomized control study on the mixed ulcers, we have the big theoretical background and some prospective study showing us that this treatment can be efficient. However, I think that we need a little bit more evidence, but it's right. Solotic side is improving and the glycocalyx, and this was also recently documented in some electron microscopic studies that with this drug we can get such a result.
Thank you.
Thanks.
Thank you. It's my pleasure to introduce Dr. Josefina Carvalho. She is specialized in angiology and she's member of Venezuelan Society of Lipology and Lymphology. She is live with us. Please go ahead, Dr. Josefina.
Estás muteada.
You have to switch on your microphone.
Buenos días a todos. Excelente presentación, doctor Tomás. Concuerdo con usted también con la utilización de drogas venoactivas, pero siempre acompañando procedimientos flebotrópicos. Realmente yo las utilizo desde mi formación en Brasil en 1993, siempre acompañando todos los procedimientos flebológicos que he realizado. En relación a la fracción flavonoide, creo que mejora mucho la sintomatología de dolor, pesadez, cansancio, y para mí también el pseudocide ha sido muy bueno en la cicatrización de las heridas. Yo tengo una alta evidencia porque la he utilizado en la cicatrización de heridas de úlceras vasculares. ¿Ok? Mi pregunta, tengo dos preguntas. ¿Cuánto tiempo usted indica a sus pacientes la droga flebotónica y qué pautas usted toma para suspenderla o prolongar su uso, siempre acompañando todos los procedimientos flebológicos? Muchas gracias.
My Spanish is rather poor. Can I get any help?
Es muy rápido.
Can I translate this question? It's possible.
Yes, Thomas. How many times do you use the venoactive drugs in the patient?
¿Por cuánto tiempo usted indica a sus pacientes drogas venotónicas y cuál es la pauta? O sea, ¿qué considera usted para retirarla o prolongar su uso cuando las indica? ¿Sí me escuchó ahora?
Zafir, can you help me?
Asking about the duration of treatment.
Maybe you are off from the English channel, Thomas.
No,
I am the English channel.
I am in English. I mean, should I switch on?
Yes, select the English. In the bottom of interpretation, select the English.
She's asking how long would you keep your patients on venoactive drugs?
Okay, sorry, I did not realize that there is translation. My fault. So if I see that the treatment is efficient and we are not another way to treat the patient, like doing the procedure or using also decompression, I keep this patient long with the venoactive drug, and I think it's not a mistake. we do not have any limit. However, opposite situation, if I have patient who is taking the drug 1 or 2 months and I don't see any efficacy of the treatment, the patient reports exactly the same, I would try first to switch to another treatment with phlebotropic drugs, or withdraw this treatment if this is unsuccessful. So the only indication for me is to use the prolonged treatment is that I see that this treatment works. Some people, I spoke about this several times during various meetings, propose the treatment for 3 to 6 months, then they do the break. But in reality, we do not have any proof that this works. So if this is successful for the patient, if the patient can live normally, many of these drugs are based on the natural compound. We have just 2 or 3 synthetic drugs in the market. That's why with all these natural drugs, I think that prolonged therapy is possible even for a long time. The condition that is required is that this has to work. We saw that number needed to treat in some of the drugs is like, 10, 11, 17. So it means that there will be a big group of patients when this treatment was failed.
Thank you. Thank you.
Thank you.
And now it's my pleasure to introduce my friend from Mexico, Dr. Javier Serraldi. I hope I'm pronouncing his name correctly. He's Secretary General of the Academia Mexicana de Phlebologia y Entomologia. He's professor at the Institute of Mexico for phlebology, among many other important commitments. Dr. Javier, please go ahead.
Thank you. Hello to everybody. First, I want to say thanks to Professor Rashad Bishara and the committee and the invitation to me, and congratulations to Professor Urbanek, because we can look the wonderful and very interesting presentation about the benactive drugs. Well, when we decide to talk about the benactive drugs, it's very important to remember the pathophysiology process and the progression that the venous and lymphatic disease has. Because as the first objective of the use of the treatment, in this case, it's to attack the endothelial inflammatory process and reducing the rolling, adhesion, and migration of the leukocytes inside the endothelium, because they have shown to reduce the damage at the venous wall and favoring the venous and lymphatic return associated with change in the microcirculation. Taking into account the guidelines published in 2018 in relation with the use of benactive drugs, these shall always be used in patients with presence of the symptoms in the chronic venous disease, and demonstrating the beneficial effects because they have been increasing the venous tone, decreasing the capillary leaks, favoring the lymphatic drainage, and reducing the free radicals, especially talking about the flavonoids with the high level of evidence type A. But the most important part is to analyze all of the guidelines and publications about the venous and lymphatic disease. And don't forget that the mixed therapy, like to the use of the benactive drugs and the compression therapy together, have been the best therapeutic strategy and consider the best alliance to our patients. Thank you.
Well, I think that the company would like to hear that the drugs stop the disease progression clinically, and this is something that probably would be the best message for them. But till now, we do not have any proof that we can use, even if we know that this drugs works at the level of the endothelial cells and that we can stop inflammation in this region. We do not have any scientific proof that this will stop disease progression. Personally, I'm not using the drugs in these indications. Many people, many patients come, and probably you also get the question, what can I take to not have new and more spider veins, reticular veins, or these things that the patients are sometimes worried about because they see their legs and disease is progressing. So we probably cannot show any proof that any of our drugs, which we use in daily practice, can stop the disease clinically, even if we have theoretical background I would not consider this indication as very valid at this moment. Concerning the combined treatment, as I tried to show during my lecture, for sure there is the space for the medical treatment in combination with compression, risk factor elimination. Also, if we have the patient which remains symptomatic after the invasive treatment. So in Poland, we made the research on the adult population of the Polish people, that it turned out that we can have like 60% of all the adult population with the symptoms concerning the lower legs. 40% of these patients are taking diet supplements or medications. So it's a huge number of patients. If they do right or wrong, this depends on the indications, but each case should be analyzed individually. Thank you.
Thank you, Professor Orbenek. Your presentation was truly enlightening for all of us. And now it's the last part of this webinar, the final remarks by Sergio Genassini. He's known to all of us, and he's really the man behind this educational event.
I'd like to thank a lot of friends and colleagues and congratulate the wonderful speakers of today. They offered us the opportunity of providing some remarks and diving a little more into the literature. Indeed, in honor of Claire, I would like to start with the bond that is linking together veins and lymphatics, and Mabel offered us the opportunity to look at that. And if we look at this paper, we see clearly how there is a lymphatic drainage delay in the region of varicose veins. She also offered us the opportunity of diving into the topic of obesity, that I would consider the presence of a venous disease where there is no venous disease to treat, meaning that we have to treat obesity in this case. And indeed, you see that in this publication, we have no ultrasound detection of venous disease, when in reality, we have C4, C6 patients. And this has been clearly demonstrated also by this paper showing the shared stress pathological presence in obese patients compared to control. BMI is an interesting topic, I think, particularly if we look at the lower limb having a higher BMI as a risk factor and the pelvic venous drainage having the BMI being reduced as a risk factor. Mabel also talked about the platelet factor 4 that reminded me of an investigation we did in the University of Atlanta about platelet factor that is in a similar line, showing us how these patients might have an increased risk of thrombosis. And indeed, this is in line with the clinical data of Chang, showing us how our varicose veins patients have a risk of DVTs that can pile up to 5 and more. Mabel also talked about the importance of the posture, and I couldn't agree more. And it was Professor Hull showing us the importance of a correct posture and weight bearing being potentially risk factors for venous and also lymphatic drainage impairment. Laura Redman showed us the opportunity of a procedural approach to lymphedema. This reminded me of the group effort we did in the winter 2019 meeting, for which I'd like to thank all the ones involved in the publication of this document that is available for free in the Phlebology Journal, touching the topic also of lymphedema in the dedicated chapter, pointing out how we definitely need standardized and reproducible data for coming to a final recommendation for pillars of the therapy like CDP. Otherwise, we get the risk of comparing apples and oranges, and the same thing for the surgical approach that cannot, of course, be considered as a standalone treatment. Now, there are different techniques proposed, and all the authors are supporting them. It's very important to have a head-to-head comparison with homogeneous data before coming to a final conclusion. Professor Urbanek has always delivered a brilliant lecture on venous active drugs, and a chapter was dedicated also to this topic in the document I was mentioning before from the winter 2019, pointing out how we should never talk just about venous active drugs in general, but specifically address the single drug for the specific signs and symptoms, so not to compare apples with oranges. He mentioned MPFF as supported in 6 clinical classes indeed, and also sort of excited as an interesting opportunity for anti-inflammatory, anti-thrombotic action on chronic venous disease patients. I'd like to take this chance to remind that, of course, CF cannot be a quantitative severity scale. is not there to tell us the severity of the condition. So we should always remember this, as we should remember that future investigations should be addressed to the importance of the correlation between hemodynamic parameters and the patient's reported outcomes and quality of life in general, together also with the evaluation of the psychological component associated with the drugs administration or not. We should also remember that a dilated varicose vein is not a pathological vein always. We should always assess it properly, think about, for example, spot varices. But of course, this does not mean that spot varices are always healthy, and we might have to treat them as well. As we might have to address properly subjects who are not affected by evident chronic venous disease, but that might present venous signs and symptoms after occupation or, for example, overload. And this has been clearly demonstrated as a risk factors for venous hypertension development. Now, if we think about the venous active drugs outside the lower limb region, we can think about them also in the pelvic venous disorder district. And indeed, we have preliminary data supporting MPFF role in this scenario. As it is always important to go back to the leading cause of preventable death, which is thrombosis, remembering the risk that we have with our varicose vein patients, for which drugs like sulfexide, of course, can be of help, according to the latest data published also by this revision of big data. Particularly in a time in which we might want to give extra points to our patients because of the potential presence of a positive asymptomatic case after, for example, a venous procedure when the patient is discharged, for which we really want to have a proper risk assessment to properly protect the endothelium of our patients and the vascular system in general. And there was mentioning the endothelium because indeed we recently identified the presence of important receptors on the endothelium. In this case, not of the veins and arteries as it was already demonstrated, but also of the lymphatics. In human first identification of our knowledge, indeed, of the glycocalyx and the lymphatics, that is paving the way for an important synergy between the venous and lymphatic system in the management of the patients of chronic venous disease and of lymphedema scenario. For this, I like to conclude, pointing out the importance of grouping together for fighting misinformation. We've been pushing this for months now, that it's very important that we report eventually encounter the venous and lymphatic misinformation in whatever language. And I deeply thank the more than 70 scientific societies involved in this group effort that will lead to the creation of a consensus document to be presented during the once-in-a-lifetime opportunity of the Universal Expo in the beautiful Dubai next February, when I look forward for being together in person again for 300 people, and at the same time online or connected. I'd like to thank you deeply, LATAM and Africa, for having connected once again, together with all the continents sitting in the LAT-AF 2.1 version. Thanks to all the organizer of the event and the participants. Thank you.
Thank you, Sergio. And I would like to thank all the participants, the chairpersons, the moderators, the speakers, the discussants, and our esteemed guests from North America. Thank you all. And before I leave, I would like to thank Servier, without whom this would have been impossible. Servier has actually sponsored all our Latin America and Africa joint webinars. And now Professor Oscar Bottini will do the final words.
Gracias. Quiero tomarme 2 minutitos para hacer algunas reflexiones sobre esto. Primero, felicitar a la doctora Wasil, al doctor Rayad, que desde África han realizado webinars. Obviamente es un trabajo en conjunto que venimos haciendo desde hace mucho tiempo y quiero felicitarlos por la excelencia de los ponentes que hemos tenido hoy y por estar siempre al servicio de la educación. En función de eso, quiero hacer algunas menciones respecto a la presentación de Laura, de la doctora Redman. Gracias, Laura, por tu presentación, ha sido excelente. Solo 3 reflexiones me quedan con esto. Nosotros hemos recibido al doctor Brorson desde principios de este siglo varias veces. Una de ellas fue en el congreso tal vez más importante que tuvo Latinoamérica en el 2014, y siempre él remarcó la necesidad de tener un pitting negativo, es decir, la digitopresión que sea negativa al momento de hacer la lipoaspiración, y esto es importante mencionarlo para la educación que se pueda tener, ya que debe tener ausencia de todo edema al momento de la presentación. Para eso requerimos de un drenaje linfático previo muy importante. Segundo, es que la compresión posterior al procedimiento debe ser por periodos altamente prolongados y generalmente por encima de 40 milímetros de mercurio, como mencionó la doctora Mabel Busati, con tejidos planos, lo cual es difícil y que solo estos procedimientos los podemos hacer en aquellos pacientes que tienen dificultad en el calzado, dificultad para colocar una media o que tienen deformidad del miembro, como se han mostrado los casos. Con respecto a la doctora Mabel Busati, comentar que ella está en un servicio público, con todo lo que esto implica, con las dificultades que tenemos en los servicios públicos. Ustedes saben, nuestros hospitales, tanto el Hospital de Clínicas, donde compartimos con la doctora, como los hospitales privados, yo tengo la oportunidad de estar en ambos, y la situación es totalmente diferente. Por eso, mis felicitaciones a la doctora por su presentación. Solo hacer mención que Farship y Weiss describieron el linfedema masivo localizado en el año 98 y desde ahí nosotros regulamos una técnica para estos pacientes, para el linfedema localizado, que son pacientes que aparecieron con la aparición de la cirugía bariátrica, antes eran desahuciados. Así que cada vez más vamos a ver estos pacientes en combinación entre la hiperobesidad y el linfedema. Por último, felicitar al doctor Urbanek por su presentación, recordar siempre en el C0, recuerdo esos pacientes de C0 con las molestias sintomáticos, con esas molestias, y nosotros tuvimos la oportunidad de realizar un fase 3 que fue presentado también en el 2014 con una nueva incipiente en la droga Ensayet, y ahí mostramos que realmente es importantísimo tratar estos pacientes desde el C0. Y una pregunta que siempre nos hacen los pacientes, si deben tomar la medicación todo el año o solo en invierno o solo en verano. Es muy común en nuestra región que solo se tome la medicación durante los tiempos fríos. Sin embargo, esto debe ser revisado a futuro. Por último, quiero felicitar a todos los que hicieron comentarios durante esta presentación, agradecerles por esto y pedirles que participen de una reunión que vamos a tener el día jueves a las 20 horas, hora Argentina y hora Paraguay, que se va a realizar con la Sociedad Paraguaya y se va a hablar de congestión pélvica, así que los invitamos a participar allí también. Por supuesto, no dejen de participar en el próximo congreso en Dubái, que es nuestro próximo gran evento, y les solicitamos a todos que se apuren ya que tenemos solo 300 lugares para esta presentación. Así que muchas gracias, gracias Rayad, gracias Wasila, a todos ustedes.
Thank you. Bye-bye.
Thank you. Thank you so much, all of you. Have a great weekend. Thank you so much.
Bye-bye.
Bye-bye. Bye-bye. Goodbye, Zoe.
Thank you.
Gracias a todos. Chao. Saludos.
Bye. Adiós.
Chao.